Barrett's esophagus is kind of the major risk factor for adenocarcinoma of the esophagus. And adenocarcinoma of the esophagus was basically unheard of until the 80s when it was first reported, and it is one of the very few cancers, perhaps the only solid tumor that is actually increasing in frequency in North America. Worldwide, squamous cancer is still the most common esophageal cancer, but in North America, Europe, it's adenocarcinoma. So 75 to 80% of our patients with cancer have this type, adenocarcinoma. And Barrett's esophagus is the major risk factor for that.
Advanced screening is extremely important because it allows us to make an early diagnosis. Early diagnosis allows us to treat and even cure patients of their Barrett's esophagus and precancerous changes before they have a chance to progress to cancer or even worse, invasive cancer. Currently, we still take random biopsies in addition to targeted biopsies to look for precancerous changes. In patients who have no precancerous changes, they require surveillance every 3 years. In those with any precancerous changes or dysplasia, either low-grade dysplasia, high-grade dysplasia, or intramucosal cancer, that's when we consider our more advanced modalities for endoscopic resection, and really we call it endoscopic eradication of their dysplasia and the Barrett's esophagus itself. The other reason we need to work so hard at preventing the progression of Barrett's esophagus to dysplasia to cancer is that we know that the 5-year survival rate is extremely poor.